So my name is Arin Piramzadian. I'm a emergency medicine physician, like she just explained. Our talk today is how to alleviate the impact of COVID-19 on the Hispanic community of North Carolina. So I want to introduce you to Jose. So Jose is a 32-year-old Hispanic male. He has no previous comorbidities. He's a construction worker who had to work during the initial outbreak. He lives with his wife, his 5-year-old son, parents, and maternal grandmother. He was first tested in April due to a job site outbreak and has consistent positive results since then: April 26th, May 11th, May 27th, June 14th, and July 1st. In North Carolina, there's a pretty significant disparity in the Hispanic population's exposure to COVID-19. So in 2018, the Hispanic population of North Carolina was estimated at about 1 million out of the total population of 10.5 million residents. So with only 9.5% of the population being Hispanic, there's an overwhelming 36% of positive COVID-19 patients that are Hispanic. The causes of this significantly skewed statistic are multifactorial in nature, and they create a large socioeconomic disadvantage for the Hispanic population. Of the 240,000 confirmed COVID-19 cases in North Carolina, about 79,000 are actually missing data on ethnicity. But of the other 160,000 cases as of today, 51,000 identify as being Hispanic. Nationwide, similar statistics are seen. So one quotation states that Latino and African American residents of the U.S. have been 3 times as likely to become infected as their white neighbors and twice as likely to die from the virus. Now, in Durham County alone, the initial bar, you can see the orange one, that represents the Caucasian population. The green one is the African American population, and the blue is the Hispanic population. So you can see that the amount of positive results has grown significantly in the Hispanic population. Similarly, deaths in the US by ethnicity, you can see that it is very skewed for the African American and Hispanic populations in comparison to their Caucasian neighbors. So why is there such a disparity? A lot of the Hispanic population is considered essential employees. They work in construction, food services, healthcare services. They have very close-knit family structures, very close community structures. They share transportation. There's decreased access to healthcare, and there's higher comorbidities that are often not treated or diagnosed. So this is where StarMed Family and Urgent Care comes in. So this is my practice in Charlotte. We have 2 locations. They're actually very nice offices. I'm very proud of them. So we specialize in providing care to the underserved communities. So our initial location, Tuckasegee, has 82% African American population that it serves. And this is located on the west side of Charlotte. And on the east side of Charlotte, we have the Central Avenue location, which is 78% Hispanic American population. Our overall payer breakdown includes 30% Medicaid, 25% Medicare, and 25% Blue Cross Blue Shield. As we all know, it was very difficult to do any testing in North Carolina. As an emergency medicine physician, I had to jump through hoops initially since we were so limited on testing just to even get testing on symptomatic patients in the hospital. So I saw this as an opportunity to provide COVID testing to North Carolina. So what we did was we actually worked with a private lab, and we were able to have an FDA-approved Thermo Fisher scientific device. And we initially were able to run 96 samples every 8 hours. And now with automation, we run about 300 samples every 8 hours. We perform about 4,000 tests per week, free of cost to patients in about 18 counties throughout North Carolina. We do also have the FDA accepted but not approved biogenesis antibody test, which gives us 5-minute rapid IgM and IgG results. So some of our successes throughout this venture have been that we've grown significantly in size and public awareness. North Carolina Department of Health and Human Services recognizes the services that we are providing, and they partnered with us as one of their preferred testing providers. We currently have contracts in 7 counties, performing testing at least a few times a week in different marginalized populations throughout these counties. All the testing that we're performing is free of charge to the patient, which allows for increased testing. safer travel, and helping to get people back to work. Now we've grown quite significantly. In February, we only had 4 APCs and myself, 10 support staff. Currently, we have 38 part-time, full-time providers and 350 medical assistants throughout the state. And we're on the news about 3 times a week with different topics ranging from COVID to preventive care. Now, while we have these wonderful successes, at the same time, there's some challenges to doing such large amount of testing. Financially, we're still waiting on reimbursements for payers with significant financial expenses due to our staffing and overhead costs growing so exponentially. So about 85% of our visits have not been reimbursed by the payers yet. And like many other family practice offices, we lost many of our patients out of fear of exposure to COVID-19, but more so as a result of us being seen as more of a testing location and being higher risk than other facilities. So let's go back to Jose. So why did Jose continue to test positive? Now, this is a study in Singapore regarding the microbiological data for a period of infectivity and viral RNA shedding. It's a very interesting study. So based on analysis of 766 patients, it indicates by day 15 from the onset of illness, only 30% of COVID-19 patients are actually PCR negative by nasopharyngeal swab when retested. So this goes up to 68% by day 21, 88% by day 28, and by day 33, almost 95% of patients are negative. So that means that people are still testing positive. Now, one of the main things that we have understood from this process is that even though the viral RNA detection by PCR exists, it does not equate to being infectious. So the data does show that while viral RNA detection may persist in patients, this persistent RNA detection represents non-viable virus, and therefore patients are not infectious. Now, while the CDC has changed its guidelines quite often, our most recent guidelines state that 10 days after your initial test, you don't need to be retested, that you're cleared to go back into public at that point, that you're no longer infectious. But while the CDC may have its own guidelines, employers often refuse to allow positive results for people to go back to work, even with a doctor's note. So Jose was kept out of work for approximately 11 weeks after his initial test, when he finally tested negative on July 10th. We did do 2 antibody tests on him. Both of them showed that his IgGs were positive while his IgM was negative, which is consistent with a chronic exposure. Now, unfortunately, he was the main breadwinner in his family of 6 people, so he had to rely on others for support throughout this whole process. Now, all 5 other family members eventually tested positive and were quarantined throughout the 2-month period, with 2 family members actually requiring medical care, but neither one of them required any ICU or had any significant mortality or morbidities. So we noticed that Jose's story of financial burden throughout the pandemic was not limited just to him and his family. Early on, with our significant number of Hispanic patients, we noticed that this is very common throughout the community. So we decided to best serve our communities that we had to take on an active role in reducing transmission rather than just being a testing center after exposure was occurred. Because realistically, at that point, it's already too late. We started initially with hiring more Spanish-speaking providers and medical assistants. Then we approached multiple construction companies, factories, and farms where we helped to implement very strict symptom checks, temperature checks daily, helped to create social distancing in buildings with plexiglass or separating where people were working. We helped them create more shifts throughout the day, so it limited the number of people at a building at a different time. And interestingly enough, while the general community and the medical community didn't have enough N95s, the K95s and the P95s were pretty abundant in the construction companies and factories, since they were the ones that normally use these. So we were able to get all of the staff and the employees masks. Now, an interesting aspect of transmission in businesses, it's not more so while people were working, because while they were working, we were able to limit their exposure. It was actually during lunch breaks where people would congregate together, and often food and drinks were openly shared. So in one business, we encouraged them to actually provide boxed lunches for employees. And for the others, we actually had them close their cafeteria areas and have the staff eat outside. Another main actual transmission was how people were commuting to work. So oftentimes, multiple people from different families would often get into the same vehicle, and it would just easily spread throughout to other homes. So we were able to get people to actually drive separately, which, environmentally doesn't help, but in regards to the pandemic, it was actually successful to limit exposure. We also decided that often the males in the family would not openly seek medical care. So we targeted the females at home by buying ads on Spanish radio stations, where we offered our cost-free testing, as well as having our providers on talk shows discussing various medical issues related to COVID. And people would be able to call in and ask questions, so it was actually really successful. With improvement of test result turnover times, obviously, when we first started, everyone was taking about 10 days or so to get results. Now we get our results back in about 2 days. We're often able to test factories on Fridays and have their results back by Monday, where the employees can start their shifts in the beginning of the new week. In one facility alone, by doing all of this, we were able to cut the positive results from an initial outbreak of 13 employees to consistent 0% transmission in office for the past 3 months. Of the 2,350 tests we've performed from our 4 major occupational contracts, there have been only 73 positives, which is a 3% positive rate, lower than the state average of 5.7%. So all of our goals throughout the pandemic have been, to limit the medical impact of COVID-19. Unfortunately, we do miss the socioeconomic aspect of the disease, especially in those marginalized populations that need our most attention. So with the emphasis from the North Carolina Department of Health and Human Services and our local health departments, we do hope to help to protect our communities and alleviate this burden, specifically by targeting those marginalized populations and doing what we've done so far and trying to expand our services. That's all.
Thank you, Arin. Such important work, and it makes such a difference, and we appreciate all that you're doing for the state of North Carolina and for many families and workers and helping during this COVID epidemic. It's so important. So thank you so much.
Thank you.
We're opening up for questions. It looks like Amy, Dr. Marietta had a question. How are you handling uninsured patients, particularly since there is a high rate of uninsured among the Latinx population?
So through the CARES Act, there is a percentage of financial money that's available for anybody that takes care of patients that are uninsured. So all you have to do is talk to your billing department, have them submit that to the fund so you can get reimbursed. Approximately 30 to 35% of our patients are uninsured.
Thank you. Other questions? It looks like.
Do you have a question in the question box?
I see. Excellent work. Thanks for your dedication. Oh, is it another place?
There's another
Q&A.
place.
Oh, okay.
Yeah.
I got it. Dr. Apollinario, how do we extrapolate these lessons for the upcoming flu season with regard to the Hispanic community?
The interesting thing is, I feel like we should have had something in place since we've had influenza yearly. We should have learned from this. The problem is now that it's hit us so hard and everything is going to combine with the influenza season coming up, it is going to be pretty concerning. So what we're actually doing is we are having all of our sites provide flu vaccinations as well. So we are going to vaccinate all our patients that are willing to do so. And then we do also have the flu antigen devices from Sophia. So we are going to be testing for influenza as well at these locations.
Okay, thank you. I see a question from Dr. Keever. How will you make up for the funding deficit for non-paid or late pay insurance care?
So that's a very good question. Currently, we're about $1 million under budget. So it is definitely a little painful right now. So we've gone into our personal funds to pay for this, realistically.
I can imagine. It's a very difficult situation. And Dr. Rayner, are employers willing to accept antibody test results instead of only PCR testing results? And this might be the last question, and then we can move on to our next speaker.
So the problem is employers do not understand the differences, and the general public, to be honest, does not understand the difference between antibody, antigen, and PCR testing. So patients will come to us asking for antibody testing for clearance. My providers are under strict instructions that we have to explain what antibody testing really means. A rapid antibody should not be clearance to go back to work. However, patients still want it and still give it to their employers, and unfortunately, they do go back based on negative antibody results. Especially those symptomatic ones, we tell them, honestly, you can do this test, that's fine. This is not the appropriate test. A definitive PCR testing is what's required. I do believe antigen testing now is being accepted by the health departments as a presumptive positive. So if you look on the NCDHHS website, there was about 9,000 presumptive positive antigen results that are just listed today.
That is correct. And there's specific guidance about antigen testing that the department released, I guess, about a week or so ago. So thank you. Okay, thank you, Arin. Thank you so much for this important work and your continued information.